now. This is the Countdown Data Analysis Center webinars. Today, we're focusing on the effective coverage, the Data Analysis Center. Before we jump into the presentations, a few housekeeping. If you have questions, please, throughout this presentation, please, you may use the chat to pose questions, and we'll get a chance to see them and respond. Might not respond while the presenter might not see them, but I will make sure that somebody is following up. And the link to the French version will be posted on the chart as well, so you can have access to the link to the presentation in French, as well as a translation, a simultaneous translation into French is happening. If you go, I think underneath your Zoom, you'll see the language tab there, and you'll be able to select French for the to listen to the presentation in French. All right, thanks so much. And let me try and see if I can move this. Okay, well, so today my name is Agbesi Amuzu, and I will facilitate this webinar with my colleague Melinda. I'm not sure, Melinda, are you on?
Yes, I'm here. Good morning,
okay.
Everyone.
Hi, Melinda. Today we'll be presenting to you work that we have started. Many started now. Actually, Countdown is now going into this area of work. Is a new area of analyzing, measuring and analyzing effective coverage. So it's a new topic that we are expanding on. So our presentation today will be on analytical tools that we are developing for countries to use. It's still under the development, and hopefully we have them available to you. So these are the faces of people at JHU working on some aspect of Countdown. You may come across them. They are not all involved in the effective coverage analysis, but any of them will be able to direct you directly to us. As an outline, I will start by introducing, doing a quick background on effective coverage, then pass on to Maiga Abdullahi to tell you about the data sources. Elizabeth and Safia will come in to introduce the tools that we are working on effective coverage, and Emily will come in to show you what we are developing for data repository. And then we'll open, I think we have other resources. Melinda will come in to talk to you about the project, the improved project that she's leading, and the work that she's doing on effective coverage, and we'll have a chance to open for questions. So coverage is the link between programs and impact. Right? So this framework shows you that high coverage is an essential pathway to mortality and fertility reductions and improvement in stunting. But how do we define coverage? Let me see. What is coverage? Well, coverage is defined as the proportion of the population in need of an intervention who actually receive it. For example, skill-based attendant is referred to as a coverage of skill-based attendant. It's the proportion of births in the last 2 years who were delivered by a skilled health professional. It could be 2 years, could be 5 years, depending on what you choose to use. This is typically different from other concepts of coverage, such as training coverage or health facility coverage. But defined as such, it has some good properties. For example, it's easy to interpret, to understand, and to compare. However, it has some limitations as well. For example, it requires accurate measures of the population, actually the population in need, and does not actually capture measures of quality of care, as we will see in the next slide. In many cases, also it measures only the contact with a health service. So since its debut in mid-2000, Countdown has been monitoring the coverage along the continuum of care. This graph shows you, compares interventions across stages from reproductive, pregnancy, birth, postnatal, infant and child health, and environmental indicators. You could see the typical trimodal graph with high coverage for neonatal tetanus protection, skilled delivery, and then infant immunizations, and then environmental health. This continuum graph is developed at global level, but also produced for each countries, and you can have it available, see it at the Countdown website, where you can download each country profile. So then we have this, then why are we talking about effective coverage? Well, you see that based on our definitions of coverage, you need, all you need is to capture the need for an interventions, the utilization of a service, and the receipt of the service. So we don't talk about whether the service were provided with good quality that's necessary to satisfy the need. And we also don't talk about whether the patients adhere to the prescriptions and whether we take into account the efficacy, actually the efficacy of the intervention itself. So effective coverage then try to capture all these elements, right? But then how do we measure it? To do it may require combining multiple data sets, agree on what we call quality of care, and define clearly what effective coverage is. So we try to operationalize this construct through a cascade, a coverage cascade that help understand the loss of coverage at each stage. This was inspired by other frameworks such as the Tanahashi framework. So we start from the target population that is in need of an intervention. Then we assess those who visited a health service, and then those who visit a service that is ready, that has all the input. And then you can look at, see that, some of these services may not, you may visit the service that's ready, but still not receive the service. That's a missed opportunity. So we look at the crude coverage, that's those who actually receive the service. And then you could receive the service according to the standard, the country standard regulations. Then now you have a quality adjusted coverage. And then users must adhere to the prescription, to the recommendations, that's user adherence. And finally, to do a full gain of the benefit, you need to take into account the efficacy of the interventions. Now, this is not necessarily a linear, cascade. And some intervention may not necessarily fit, this, as you look at, for example, some nutrition indicators. So here's, for example, an example of how this is used. These authors have used a clinical observation of provision of family planning services to measure quality of care. Then they use the link to household surveys to measure the quality adjusted coverage. This graph shows you that while the family planning demand satisfied is high, this bar, the bar represents the family planning demand satisfied. When it's adjusted for the quality, you see the darker brown shows you that the quality is low across all subnational districts. Another example that link household survey to facility survey, you can see here that first antenatal care or for more antenatal care is higher than when adjusted for the availability of testing or management kits for ANC. The measure drops substantially. This suggests that quality of care that women are getting is much lower than the crude coverage, generate a coverage that's much lower than the crude coverage that we get directly, and then maybe overestimating the actual positive gains in the population. So this is a quick intro on to the what effective coverage is. Maiga will take on to tell you a bit about the data sources, how we will combine data sources to do these measures. Maiga, can you take over from here?
Hi, Agbesi. Hi, everyone. Okay, thank you. So as Agbesi said, I will take you through some traditional sources of data used for effective coverage. To do so, we need our data from household servers and also data from the facility. And for facility, we have data coming from health server or from a routine health information system. So household server will traditionally be used for service contacted and also for traditional coverage. And then facility data as well as health facility server data will be used for the linking that will help us now to measure the different type of effective coverage Agbesi talked about earlier. Next, please. Okay, these are some sources of data. So we focus only on household server and health facility server data. Just to provide an idea to people where they are able to get such information they need for the effective coverage measurement. The health for the demographic and health surveillance system, demographic and health server and mix of data are the main sources for household server. And also we have additional sources we are able to see. Now, most of them are open access data. And for the server coming from country, or some of them are very, very difficult to get access to them. Next, please. Okay. Agbesi, next, please.
Next.
Okay, here are some key relevant which I include into SARA, the SARA and SPA data. So service assessment and rhythm assessment from the WHO, and the SPA, which are service provision assessment from the DHS program. Here we are able to see the main type of health services which are included in these server. So we have services included in the continuum of care from family planning until child curative care and going through ANC, maternal and newborn care. And we also have some additional type of services like NCDs, surgery, mental health, and so and so. People may also be able to get from SARA and SPA data. Next, please. Can you come back, please, Agbesi, on the readiness, please? Yeah. Okay, these are the readiness data. So the readiness include the availability of health services and to what extent the facility are prepared to provide the services. And in addition to the readiness, we are also able to get data about the provision of care, or some people also call the process quality, which help us to measure to what extent the service delivery process follow generally accepted standard of care, and also to assess whether a client and service provider are satisfied with the services delivered in the health environment. Let's see now some component of the different data. Yeah, this is just a tool we use to try to visualize the different component of the health services. So this is an example related to IMCI, where from the IMCI we have two types of quality of care: service provision or service provision or quality of care, process quality of care, and also service readiness. And for each type of quality of care, for instance, readiness, we do have some domain like availability of services, equipment, training, medicine, and also diagnosis, for instance. And then also we are able also to have some domain for each of the service provision, as we are able to see a physical example, health history, entry the treatment. And for each quality of care as well as each domain, there is a way to compute now the score that can be linking now to the effective, to the traditional coverage, and be able to measure the effective coverage. Next, please. Okay, here it is an example of an example showing for instance, for availability of services. I say that there is the health service, okay, and then the health service, you also have the quality of care, and then the domain. And for each domain, and also there are a few items, okay, we need to be able to populate the score relating to the domain. So this is an example of how to populate the example for the score for availability of services. And for this example, there are a few items we need to take into account, like the preventive and care services, if it's available, malnutrition, also availability of ORS and zinc supplementary services, and so and so. So just to summarize, saying that, okay, going from health services, we are able to get a different type of quality of care. And then for each type of quality of care, there are also some domain. And then for each domain, we need some item or variable to be able to populate the score for the domain quality of care or health service. Thanks.
Good. Elizabeth?
Yeah, good afternoon and good morning. Just trying to get my video on. All right. Yeah, so I'll go into I'll do a quick discussion of one of the analytical tools that we're proposing to develop, that we've begun to develop, and this one is around coverage tool. Next slide, please. So the main component of the coverage analysis toolbox will be downloadable statistical codes or scripts to generate coverage estimates typically used in countdown analysis. These scripts will be organized by a set of indicators like reproductive health, maternal, newborn, child health, and nutrition. The code will produce estimates consistent with DHS and mix, with the 95% confidence intervals adjusted for survey design. They will also create common stratifiers used in equity analysis, such as SES, maternal education, maternal age, and others. We'll make them available in Stata and R statistical packages, and they'll be annotated to be customizable to your country data and the type of analysis performed. They will also generate ready-to-use tables for graphs, small data sets with coverage indicators and selected stratifiers for further analysis. The coverage analysis toolbox will also include video tutorials on how to run the codes to generate results, and they will also include a repository of other coverage and equity analysis resources, along with resources on how to access some of the publicly available data sets that Micah just reviewed, such as the DHS, mix, and SPA. I noticed there was a question in the chat box about Sarah. That's a little bit different, so we'll come to that at the end. For an example of a tool for the coverage analysis, next slide, please. So like I said, these downloadable codes will be organized by maternal, newborn, child health, and nutrition indicators, and also by surveys. You'll have a downloadable code that's relevant to mixed surveys. You'll have a downloadable code that's relevant to DHS round 7, DHS round 6. The code you'll have the survey design for each of these. It will be annotated to count on indicators and also to create stratifiers. And as of right now, we're developing the code to produce tables for output and or other graphical software, but we can certainly develop code for creating these figures directly as well. Next slide, please. All right, so I'll review some example stated code now over the next few minutes for ANC1, form or visits of ANC, facility delivery total and public versus private, and also go over just a quick by maternal age. Yeah, so this portion, this is a screenshot of some of the example code that we created in Stata. There is code for opening a data file. In this particular example, we're showing Bangladesh DHS 2014. There's also some code to help you set the survey design to get the correct indicators using this survey weights and also the 95% confidence intervals and standard errors that take into account the survey design, such as the clustering and any stratification. Next slide, please. All right, this is some example code on how to compute ANC1, or at least one visit of ANC. We're going to try to annotate this heavily so you can customize a little bit. For instance, I believe the Bangladesh 2014 only asked about maternal health in the previous 3 years. Some of the DHSs do the previous 5 years. So you can customize the code to look at and also different births. This example here is for the most recent birth, but we'll include some example code on how you can expand it to births, for instance. And we'll also include code for correctly generating the weighted proportions and the 95% confidence intervals. And in here, there's also code for 4 or more visits of ANC. Next slide, please. All right, this shows the portion of the most recent previous 3 years that includes institutions. We're marking areas where you would need to go back and look at the DHSs. Like, for instance, even in the same country, the response code for public versus private will change across the different rounds. So this is just an example of how we're sort of bookmarking or highlighting areas in the code that you would need to make sure you customize or carefully check. And again, this is some example code to create facility delivery, private versus public, and then also generate the weighted proportions and standard errors, confidence intervals. And then finally, I included a little example on how to compute the proportion of women with the birth in the previous 3 years who were younger than 18 at the time of delivery or older. And then also included at the very bottom is some code on how to do a stratified analysis by this. Right, next slide, please. We've included data code on how to output data for visualization. So this code here will create a text file that can be copied and pasted into an Excel file or any other statistical software, graphical software of your choice. And then you can use Excel to generate an example table like this. This is just looking at ANC1 and ANC4 by maternal age. All right, and then my final slide, I think. Yeah, so as I briefly mentioned at the beginning, the toolbox will also include some tutorials and a resource repository. So we are planning to generate short video tutorials on how to use this code to generate the indicators, do a short stratified equity analysis, and also create some graphics. We'll make these available in French and English. And then we'll also link to resources analyzing coverage and equity. For instance, the WHO Heat Plus tool is a good tool for doing equity analysis, and also the stat compiler at DHS, and then some other resources as well. Thank you very much. On to the next person.
Sophia?
Great, thanks. Yeah, thanks, Elizabeth, and hello, everyone. So as we mentioned earlier, we are working on developing a variety of tools for analyses of quality of care as well, covering the entire continuum of care from family planning through child treatment. And the goal is really to allow you to compute facility readiness and process scores, conduct linking analyses between households and health facility surveys, and generate ready-to-use quality-adjusted indicators. The tools, as Elizabeth mentioned, will be comprised of annotated data and R codes that can be customized for each country in order to allow you to produce smaller data sets and generate graphics, etc. We'll also be sharing tutorials on how to use some of these tools on our website. Next slide. I'll now take you through an example of a tool for quality adjusted coverage analysis, and this will focus on antenatal care. Next slide, please. And what I'd like to do for today's webinar is to share a step-by-step handbook on how we measured quality adjusted coverage of antenatal care in Bangladesh. So let's get started. Next slide, please. In order to generate quality adjusted coverage estimates for antenatal care, we will need to link household surveys with health facility surveys. So the household survey, which was a DHS in our case, will provide data on women's service contact for ANC. And the health facility survey, which was a SPA in our case, will provide data on the readiness of the facility to provide ANC. So the first step in this analysis is to align the facility types included in both surveys, and by developing what we call a provider crosswalk. So in the case of Bangladesh, on the left, we map out the facility levels from the SPA 2017, and on the right, we map out the place of ANC reported by the mother in the DHS. And what we do is we try to align it with the SPA health facility categories, as these are the categories that we will use for the rest of the analysis. So as you can see, in the case of Bangladesh, this was fairly straightforward, but it does vary from one country to another. Next slide. Great. So the second step in the analysis is to define the facility readiness for ANC using the health facility survey. What are the items that will characterize readiness of facilities to provide ANC services? So for Bangladesh, we used the SPA 2017 and we follow the methodology described by Sheffield and colleagues at JHU, whereby we used 18 items essential to ANC services and that were categorized into 5 broad domains: equipment and supplies, diagnostics, medicines and commodities, basic amenities, and human resources. And so these are the items that we will use to generate the facility readiness score for antenatal care. Next slide. Okay, so now that we have defined our readiness measures, let's go ahead and generate the readiness score. So we create binary variables for each of the 18 items that we included, and we assign a value of 1 if the item is available and functioning in the facility, and 0 otherwise. So all the items are binary, except for the human resources item, which is the proportion of ANC staff trained in the past 2 years. So this item will range between 0 and 1. And this is a snapshot of what your data should look like. Next slide. Once we've created our item variables, we are ready to calculate the ANC facility readiness score. So it's a simple additive score where each item is weighted equally. So it's the sum of all the item values divided by the total number of items, which was 18 in our case, and it can be expressed as a percentage. We can also calculate domain-specific scores using the same approach, but for each domain. Next slide. So now that we have calculated the ANC readiness score, we will compute the average score by facility type and administrative or geographic region. That way, facilities of the same type in the same region will now have the same readiness score, which is essentially the average score of all the facilities of that type within that region. And this is the score that will be linked with the household survey in the next step, and you'll understand in the next slides why we do this. Next slide. The fourth step in the analysis is to conduct the linking between the household survey and the health facility survey, from which we calculated the average facility readiness score for ANC. And there are several ways to do the linking analysis. Exact match linking requires a census of all the health facilities, which is rarely available, and it requires the exact name of the facilities where the woman sought care. And because we did not have this data, we conducted ecological linking instead, whereby each care-seeking episode in a household survey is linked to an average quality of care score of the providers within certain geographic boundaries. And this is why in the previous step, we calculated the average score by facility type and region. Next slide. And one thing to keep in mind is that when we do the linking between the household surveys and the health facility surveys, it's important to ensure that the health facility survey falls within the reference period of the service reported in the household survey. So let's look at this hypothetical scenario where we have 3 health facility surveys depicted by the blue triangles in 2010, 2014, and 2019. And we have 2 household surveys depicted by the blue rectangles in 2011 and 2017. We know that for ANC, the DHS will typically cover live births in the 5 years preceding the survey. And therefore, we want to make sure that the health facility surveys we use for the linking analysis fall within that period. So which surveys do you think should be linked here? Let's look at the next slide. If this was your answer, then you're correct. The health facility survey in 2010 can be linked with the household survey in 2011. And the health facility survey in 2014 should be linked with the household survey in 2017. Why? Because the quality of care measured in these health facility surveys will likely reflect the care received by the mother and reported in those respective household surveys. Next slide. In this example, however, these 2 surveys should not be linked because the health facility survey was conducted after the household survey, and therefore the quality of care measured in 2014 will not be a good reflection of the care received by the mother and reported in 2011 over the 5 years preceding the survey. Next slide. Okay, so let's get back to the linking analysis. How do we actually do it? So first, we'll go back to the household survey and we generate a variable for the place of ANC reported by the mother using the facility type that we identified from the provider crosswalk in step 1. So recall that we had matched the health facility types from the SPA to the ANC place of care in the DHS, and we said that this is what we would use for the rest of the analysis. So here's when we actually use it. Next. Now we can do the linking by merging the household survey with the health facility survey by facility type and region. And once that's done, each woman in the DHS will now have an ANC facility readiness score assigned based on the type of facility that she attended and the region in which she sought care. Next slide. So the last step of the analysis is to actually calculate the quality adjusted coverage using the equation below. So at the individual level, CIJ is the quality adjusted coverage estimate for service J, which is ANC in our case, received by individual I is equal to QIJ, the quality or readiness score developed from the health facility survey, which ranges from 0 to 1, multiplied by RIJ, which is the receipt of ANC by the woman, which is either 0 or 1, given that there is a need for ANC for that woman. Next slide, please. So what does this look like in practice? I will now share some preliminary results from this analysis in Bangladesh. So first, we explored the facilities providing ANC services and ANC care seeking in Bangladesh. And we see from the top graph in blue that it's the community clinics and the union health centers that make up the majority of facilities that provide ANC services in Bangladesh. However, when we look at care seeking in the formal sector in the bottom graph in orange, we notice that the majority of formal ANC care seeking actually occurs in the private sector. Next slide. So let's look at the ANC readiness score. Here I show the distribution of the ANC readiness score by facility type in 2017. And what we see is a gradient whereby higher level facilities such as the hospitals, public and private on the far left and far right sides of the graph have a higher ANC readiness score compared to lower level facilities in the center of the graph, where there's also a lot more variability in terms of their readiness to provide ANC. And this is something that we expected to see. Next slide. Now let's look at our readiness adjusted coverage for ANC in Bangladesh. If we look at service contact alone, which is the gray bar, we see that in Bangladesh, 92% of women received at least 1 ANC and 47% received at least 4 ANC visits. But remember that this does not take into account the readiness of the facilities to provide ANC. Now, when we adjust for the facility's readiness to provide care in the orange bar, you notice that there is a readiness gap. And we see that 66% of women with at least one ANC and 35% of women with at least 4 ANC visits likely received care from a facility that was ready to provide that service. So if all women had gone to a facility that had 100% readiness score, then we would expect that the orange bar would be as high as the gray bar, but that is not what we see. And so to improve the ANC outcomes, we want to increase the height of the orange bar by increasing ANC attendance and also by improving the facility's readiness to provide ANC. Next slide. So this is just an illustration of an alternative way to visualize the readiness score. It allows us to see how each item influences the ANC readiness score. So for example, in the top left radar plots for the equipment items, we see that the disinfectant item was the one that was most lacking, whereas the other items were fairly available. So this is a useful visual to identify specific items that are lacking and that are pulling down the readiness score. Next slide. So I'll end with some considerations to keep in mind for this type of analysis. First, there is a lack of standardized measures for quality of services. In the case of Bangladesh, the SPA surveys did not include observations of ANC, and therefore we had to rely on facility readiness using the facility inventory. There is also limited guidance about which items to include in the readiness measure or also how to combine them. And remember that the items that are included in the health facility surveys are the ones that can be measured, and therefore they're not necessarily the ones that are most important clinically for ANC readiness or service quality. The second point is that the content of ANC readiness is very much country specific and even survey specific. And as we were working on this, we realized that the variables do change quite a bit from one survey to another, even within a country. And so adaptations are needed to run analytical code. And this variability in terms of how the variables are collected and captured makes it difficult to compare readiness measures across countries, but also it makes it difficult to analyze time trends within a country. And finally, the quality adjusted coverage measure depends also on the quality measure, which, as we mentioned, it has a lack of there's a lack of standardization. So with that, I'll end here and hand it over to Emily. Thank you.
Hello, everyone. I'm going to go through briefly where to find the tools, and Elizabeth and Safia both mentioned it, but I'll go through once more just how to use the tools. Next slide. So there's two places you can find Countdown tools. One is the Countdown website. Another is the GitHub account that we've just begun populating, which is a versioning repository, which will also have all the versions of code and some toy data sets and things for you to play with or, you know, conduct analyses once we've put them up there. And just to go through the GitHub account, next slide, please. The interface is perhaps a little different from what you've used before, but the concept is the same. You would go to the URL on the previous slide and click the green button in the upper right hand corner that says code. You'd be given a few options to run the code on your desktop or to download it, and that would contain, as long as you're in the right folder, that would have everything you would need to rerun an analysis. So for example, next slide, please. If you wanted to do something similar to what Safia was just mentioning with the SPA from 2014 or 2017 in Bangladesh, you could download the code, and then, as Elizabeth mentioned, it would be available in both Stata and R. The outputs, if you can see them, I'm not sure, it's probably too tiny a font, but the outputs on these in these code screen captures are the same. The syntax is different, and that's just because that's how the two languages differ. But with these outputs in whatever your preferred language is, you can then, next slide please, populate different tables and graphs and do analysis, interpretation, and presentation of results, however you wish. And we would put for example, the shapefiles, any ancillary data needed would also go in those repositories.
Thanks, Emily. Melinda?
Yes, hi, everybody. Next slide, please. So I'm going to talk a little bit about some other resources that are available or will soon be available that may be helpful when you're thinking about these analyses and using these estimates. So I led a project called ICM and now lead a project called Improve that has been working on the methods to do this. And our interest is really to try to fill some of the gaps that Egbesi talked about at the beginning of the presentation around certain coverage indicators. So our aim was to develop methods and evidence to justify, how you would calculate quality adjusted coverage and identify or understand the limitations to those methods and those measures. So we will have a methods paper that sort of pulls all of this research together, that at least the preprint should be available this year, if not the actual published paper. And that, will sort of take you step by step through the process and where we have evidence to support methodological choices and where there are still questions or gaps in the evidence. We also have some work on sort of specific aspects of these analyses, and they're hyperlinked here. So if you have the slides and you click on the blue highlighted words, that will take you to either the paper or the preprint. So we did some fieldwork in Zambia and then also in Cote d'Ivoire, working with the mix to compare the exact match linking that Sophia talked about to different ecological linking approaches, because there's many ways to do this, to look at the validity of the ecologically linked approaches. We also did several different lit reviews, one early on just to look at the methods that people have used to link household and facility data, and another one specifically on the methodological issues in linking these data and what evidence is out there. We've also looked at the effect of cluster displacement, which is an issue with DHS data in particular. So if you're doing geolinking, then the displacement of the household survey clusters, may cause an issue. So that is available. And then coming this year, we have a secondary analysis looking at the effects of health facility sampling. So what's the effect if you're linking a sample of health facilities to a household survey versus a census of all health facilities, and also the effects of different types of facility sampling. And we did some simulation looking at how the amount of variability in the health facility data in the quality of care, to what extent that matters or that affects the linked estimates. Next slide. And then a final piece of work that may be of interest was we wanted to sort of try to operationalize some of the discussion that was happening around effective coverage cascades, which Bessie, talked about those cascades. And so what we did was to try and estimate the cascades for a variety of service areas. So for antenatal care, postnatal care, sick child care, malaria, and then nutrition in pregnancy and nutrition in sick child care. And the goal was not to say, this is the effective coverage cascade for Senegal. Say the goal was to try to do it with readily available data and to identify the issues and challenges, gaps in actually trying to estimate this for these different service areas. So those papers will also be out either definitely in preprint and hopefully the actual published papers this year. And then I think back over to Bessie for the next slide.
Okay, thanks so much. Well, we, along with what Melinda just said, we're also planning an additional methodological works, looking at alternative measures for quality adjusted coverage. Coverage, you can have preventive interventions as curative interventions, things like malaria control interventions, immunizations. We are also looking into those. And then, Melinda, Safia presented work on ANC. There's work that we are doing also on delivery and postnatal care. And finally, you'll see that we've done, we try to link facility surveys with household surveys. We're thinking now how to take advantage of available continuous routine health information data that are readily available at the country level and used to do this type of analysis on a continuous basis. So here we are. Thanks so much. Let me see. We'll open up for questions and answers. I think there are a number that came out of the chat, but before we jump in there, I would like to see whether Melinda, you have anything you would like to add?
No, nothing to add to what you just said, Igbesi. I was just responding to a question in the chat, so maybe we can go ahead. There's some great questions.
So why don't you go ahead? I'm pulling up the chat here if I can successfully do it.
Okay. So there was a question from Pelotas Kawen. I'm not sure if I'm pronouncing your name correctly. Apologies if I didn't. But I think Safia gave a good answer, but I just wanted to add. So the question is about, that we're using the region as well as the type of facility to link the household and facility data sets, and whether the region was used as a matching variable, and then how do we deal then with women who maybe attended facilities in a different region. So this is a limitation of all ecological methods of doing this linking, is that we don't know where a woman went. And so we are not in every case linking women to the facility from which they sought care. So it is possible, for example, in the Bangladesh example that Safia showed, that we linked women, to health facilities in their region when in fact they attended a health facility in a different region. The work that we did comparing exact match to ecological linking suggests that wasn't a huge problem. And we did look at, whether women were being linked to the facility from which they sought care. And in a good number of cases, they weren't, but the facilities are not so different that it mattered, essentially, for the overall estimate. So for these types of analyses, it seems to be okay. If you want to do anything sort of causal, right, you want to draw causal inferences about, the relationship between facility quality and, a woman's, whether a woman is likely to seek care, for example, then I think it becomes potentially a bigger issue. Let's see.
There was a questions on how to access FASARA data and so on. This is something we're still trying. WHO support countries to do this. So we're talking with WHO as well as the countries directly where we have opportunities at country level. So where we're working, we're talking with partners and the Ministry of Health that conducted the surveys to be able to gain access to those data. We've been successful in a couple of countries. We hope that will be many more countries come on board with their data, but it is not obvious to access. Yes.
So I think I see a question about the minimum time lag between the household survey and the health facility survey. So I think the guidance here really is that you need to think about the reference period for the household survey indicator that you're using for the linking. So for maternal and newborn indicators, typically you're using sort of ANC or institutional delivery, or potentially PNC as the household survey indicator that you're then linking to some measure of facility quality. And those indicators in the past had a reference period of 5 years. In the DHS going forward, they will have a reference period of 3 years. So ideally, you want your health facility survey to fall somewhere in that reference period. I think there's still a big question mark about, how essentially stable the health facility estimates are, how quickly they change, and if you have an estimate in 1 year, how much does it tell you about what quality is like 2 years later or 2 years before? But that's kind of what we can currently say. But if you think about sick children, the reference period for the care-seeking questions in the DHS in the mix is 2 weeks. So in those cases, for those indicators, you want a health facility survey that is as close to the DHS the mix as possible, because you want it, preferably within that reference period or very close to. So it does depend on the reference period.
And yeah, here I see PCA-based method versus arithmetic weight. Yeah, we are doing work on that, but I should say, a paper that Safia cited, Ashley Sheffield and colleagues' paper, they did compare PCA, the arithmetic means, and there was a third one, I can't remember. But it turned out that really there wasn't much difference, if not the straight arithmetic means. It's much more interpretable and understandable than the PCA-based approach. But it's something that, as suggested, as we see here, data vary from country to country over time. And so it's something we are exploring more to see how, those two approaches compare well over time. What else? I think we've answered most questions, or everybody, they were answered already in the chat. Are there any other questions? Feel free to open up your microphone and jump in if you like to.
I think that Vic has his hand raised. Maybe he has a question.
Hi, thanks. Agbesi, thanks for the presentation. Thanks for this material. I just wanted you to point out two things. These are very good tools and methods that countries could use. But countries are at different stages of the annual review. Some have started, some are about to start. And what's your advice in using the usual coverage measure or using this one? Because I know some have started using the usual coverage. What's your advice on that? Because I want them, sorry, attending this meeting, and I want you to hear from you about your advice. The other thing is a call actually to countries to really facilitate access to SPA data, because it's really important and needed for this type of analysis. And some of you actually are in collaboration where you have the National Statistics Bureaus and other stakeholders who could be good facilitators to get access to those data. So I just wanted to have that call for countries to be really open to releasing those data. Thanks.
Thanks, Sheikh. Yes, a very good point about data access. I tell you the case. We're working with countries where we develop topics for analysis, and when we're going through this, what we like to do, then they realize that really we do need those data, and quickly we're able to access those data and move on with the analysis. So it's important that we get to access those data so that the countries yourself, you can be able to do this type of analysis. Now, on your first question, Sheikh, I'm not advising saying to move away from the current way we measure coverage, unless it's it's the ways some of the methodologies have been proven invalid, and so we should get away from those. And that's a different topic, but it's still important to continue to monitor the coverage as we do at country level. But it's not enough to stop there. It's also essential to try to understand why in some countries we tend to see high antenatal care or high delivery care at 90 or 80%, while babies are still dying, mothers are still dying. And so being able to really dig down, understand that will require understanding quality, but quality not just measured at the program level or the facility level, but linked to a population-based measure, so that we can have an understanding of how overall women, what sort of quality or effective coverage women and children are receiving. So for the annual review, we'd like to see countries that we're working with, or those that are interested, be able to include this type of analysis of linking facilities and household surveys or routine data, as well as doing some additional analysis with even their survey data to try to tease out the level of quality that women and children are getting through the services.
Good. And maybe just one last item is, if a country would like to move ahead with the approach, what will be the immediate steps towards doing that, whether engaging with you, or what do you suggest? Because they are all here and they are listening to you.
Yes, get in touch with us. We hope to at least the tools, for ANC will be made available, as we said, and put on the GitHub and Countdown website. You'll have this tool available, but feel free to reach out to us. As you know, it takes more time, to develop from one indicator to another because of the variability of the data and so on. But yes, we are happy to assist countries that would like to engage in this type of analysis. So through Countdown, you can reach out to us, or through our country collaborations, we directly interface with the countries, but don't hesitate to reach out. Any last minute questions, Todd? Oh, well, we want to thanks everyone. This is work that we're still, as you know, that we're preparing and engaging. So we're looking forward to working with you and putting these tools available for use. But like I said, please don't hesitate to express your interest by reaching out to us to see how we can support you in this endeavor. Melinda?
No, just thanks to everyone for the great questions, and also to all the to Elizabeth and Maiga and Satya and Emily, everybody who worked on this presentation.
Yes, thanks so much, and to all those who prepared the webinar, Brittany and the communication team. Thanks, and see you. The next one is on I can't remember, probably on the 23rd. You'll hear from the Drivers Data Analysis Center. Thank you. Bye.
Merci, au revoir.
Thank you.
Au revoir. Au revoir.
Thank you. Bye.
Thank you.
Bye.
Bye.
Bye.